Welcome to Healthy Lifestyle. I'm Lorianne Casdia. Our goal here at Healthy Lifestyle is to inspire, educate, and empower you to fulfill a healthy, emotional, spiritual, and physical life so you can feel empowered to live the life you have always wanted and dreamed. So today we are honored to have on our show today Dr. Dominick Gadaleta. He is the chair of the Department of Surgery for Southside Hospital, a hospital in the Northwell Health group, if you will. It's also a teaching hospital. Welcome.
Very happy to be here.
So glad you are. So yeah, this is a teaching hospital, and many people don't realize it. It's associated with the school with Hofstra, right?
Right, the Zucker School of Medicine at Hofstra Northwell.
Yeah. How long has that been associated?
Well, the medical school started approximately 6 or 7 years ago, but Northwell has been affiliated with several of the area medical schools since as long as I've been involved.
Wow. So now you are the director of surgery, so you do all kinds of surgery, correct?
Correct.
But you have a specialty.
Yes, so I've been doing weight loss surgery, otherwise known as metabolic and bariatric surgery, since the mid to late 90s. At that time, it was done through the open technique where you made an incision.
Right.
Sometime in the early 2000s, we started doing minimally invasive surgery. So my areas of expertise involve minimally invasive general surgery, weight loss surgery or metabolic and bariatric surgery, and robotic surgery. We've been very involved, my group, with all three platforms for quite some time.
Now, I want to circle back to the robotics in a little bit, but so Southside Hospital started this bariatric surgery program, right? And it started this year?
Yes. So a little more than a year ago, I was asked to leave my group and my responsibilities at North Shore Manhasset to take over the chair position at Southside.
Right.
Part of the mission was not only to bring up the academics and make it a true university hospital, which it is really poised to do. It's already a tertiary care hospital and the safety net hospital for Suffolk for all of Northwell Health. But also to bring programs that were in their infancy at Southside. So that includes the robotics, general robotics.
Right.
They have a very strong GYN and GYN oncology robotics program already. So it was an easy thing to do. But to bring people with minimally invasive surgical techniques and robotics expertise.
That's why they decided to start doing this?
Correct.
Yeah.
I mean, I needed more work to do than just administer and run the operating rooms.
There you go. So you started this program there. You've been doing this since the 90s.
Yes. The
bariatric surgery, correct?
Yes.
As well as other surgery.
Correct.
So how do you think this is beneficial for everybody who falls under that umbrella of Northwell in Suffolk County?
Well, I think it's augmenting the tertiary care, being able to be the safety net hospital, but doing it in a minimally invasive way is very beneficial. The department, I think augment is the right word. We have very skilled critical care surgeons, acute care surgeons, all the subspecialties, but being able to add the minimally invasive portion, and we all work together to really lift the entire department.
Yeah, actually one of the surgeons who does and is running the program for transplants came on our show as well.
Right.
And so you're probably working very closely with that department, correct?
Yes, at Manhasset.
At Manhasset,
absolutely,
yeah. Yeah, that's really great. So how should people categorize, if you will, the surgical capabilities at Southside now compared to where it used to be? What kind of surgeries can be performed? I know you mentioned some of them.
Yeah, so other than transplants, really everything that's done at all of the university hospitals in the region. Because I've been at North Shore Manhasset since the 80s, I'm really able to bring everything that I did there, and I was the chief of general surgery there.
Oh, okay.
At Manhasset.
It's not your first rodeo.
No. And all of the quality and safety programs. So building on what they already had, which was great infrastructure, we're really able to really elevate and make it a true academic tertiary care hospital.
So, curious here. So, why did you get into surgery? What made you go into surgery? I mean, that's a really specific, highly intense proposition.
So there are a lot of different paths to surgery. I think I like seeing that I'm making a difference today. Someone, we won't get into right now why I became a doctor, but, as a primary care doctor, a psychologist, psychiatrist, you don't really see the results of your work immediately. You give somebody a pill for high blood pressure and you tell them to come back and you check their blood pressure again. Right. For surgery, someone has appendicitis, you take their appendix out, they're pretty grateful, and they get on with their life. So it's a personality thing. I'm very good at acute problems, and surgery, especially, most types of surgery that interest me involve acute problems. Especially with the weight loss surgery, which came later in my career. You do something on Tuesday, and 6 months from then, when you see the patient, you don't even recognize the patient. The family doesn't recognize. It's
amazing what you can do. Now, bariatric surgery, explain that so that everybody understands that this is not the lap banding.
Well, lap band it falls under the umbrella.
Right.
But it's not the procedure that's most in favor.
Well, and you've been doing this since the 90s. So how does it compare doing bariatric surgery now to back in the 90s? I'm sure there's a huge difference.
Yeah, so when I first started doing it, it was open surgery. So you made an incision and you did what you needed to do.
And you opened them up.
Right. And back then, more than 90% of the procedures were gastric bypasses, where you divide the stomach into two pieces and reroute the intestines so that there's an effect on volume, capacity, as well as digestion.
Right.
That procedure has never been widely accepted, even though it's still the gold standard.
Why?
It is invasive. It's a permanent change to anatomy. There are certain foods that you can never eat again or drink again. Foods rich in calories.
Can't digest it.
You can't digest it, and you get a side effect with cramps or sweats or something to say, hey, you don't want to be 300 pounds anymore, put that down.
Yeah.
And to be honest with you, there wasn't a lot of science behind what we did. My predecessors in the 80s and in the 90s, it's totally changed now.
Right.
And through the regulatory agencies that I'm involved with nationally, there are standards that we follow and protocols, and we've been able to get the morbidity, the serious issues, bleeding and infection, things like that, and mortality rate down to as safe as removing a gallbladder. I mean, safer than a hysterectomy or a joint replacement in terms of complications. But back then, you made an incision, you did what you had to do. It was almost exclusively gastric bypass, and the patient acceptance was low. That's why lap band became so popular. There was a hint that it was going to be almost as good with an extremely good safety profile. It turns out that the gastric banding is very labor intensive, both for the physician as well as the patient. If you're not constantly monitoring and checking it and making sure it's at the right level, you don't get the results that you're looking for.
Oh.
And so as we were learning...
How does one check that?
Well,
Isn't it
it's
an internal?
basically, it is, but people have to be honest with themselves and say, you know what, I'm eating a little more. Instead of saying, isn't that great, saying, I need to get to the doctor. And then the doctor has to actually be available and interested and actually listening to what the patient's saying.
Right.
So,
because that's an organ that adjusts.
Yes.
It's like an elastic waistband. It adjusts to how much you put into it, so it expands, but when it expands, it gets bigger, it has more capacity, right?
Correct.
Yeah.
Correct.
So that's what you're trying to avoid or reduce by doing this, correct?
Well, with the band, which we shouldn't spend a lot of time talking about, but with the band, it was all done above the expansive part of the stomach.
Okay.
So the sensation of fullness was above that.
Understood. Okay.
All right. What we're doing now, in addition to gastric bypass, is a procedure called sleeve gastrectomy.
Yes.
So you take the stomach from an unlimited, in quotes, capacity bag, and turn it into a tube. And when people wake up from anesthesia, the tube sensation is a sensation of fullness, right?
Oh, wow.
The brain doesn't know what we did inside. The brain just is not feeling empty.
Right.
And then when you eat, you get a physical sensation of feeling full. So it actually helps people in the modern world have control. Right? Because our bodies were not designed for 2020. They were designed for drought and famine. Otherwise, we wouldn't be here.
Right.
Right? So we needed to be able to eat when there was food. We do that now and we become 350 pounds.
Exactly.
There's food everywhere all the time.
And not a lot of activity.
Right.
Yeah.
So that's one of my sayings is we live in a world with plenty of food, but not as much physical work. Whereas in the beginning, it was absolutely the opposite. So what's changed over the years? So the procedures have changed, but also our techniques, the anesthesia techniques and the surgical techniques. So we can do an operation like a gastric bypass and the recovery be under 24 hours.
Wow.
And patients are out of the hospital.
Back home.
And back home and back at work in less than a week's time.
Wow.
When I first started doing this, I was giving patients permission at 8 to 12 days to go back to work. Now, by the time they see me on day 10 or 12, they're already back at work.
Wow. Yeah, that's great.
And that was an eye-opener for me. The patients were like, Doc, why are you telling me I can't go back to doing what I need to do?
Right, right.
I feel fine. So I had to learn that. But that has to do with also our approach around surgery. So there's enhanced recovery, or ERAS, is a brand new concept over the past 5 to 10 years. And
which is?
So it's a protocol that starts before surgery with prehabilitation.
Okay.
So fixing what you can fix.
Okay.
So if you smoke, you can't have surgery. So we have to get you off cigarettes, get your lung capacity up. We deal with things like alcohol, exercise tolerance. So, the patients need to be the best version of themselves they can be, right?
There's also an investment in that. They're investing in themselves. They're showing up for themselves.
Correct. And that's an important part. When I have a patient that's in the program that there's no effect at all pre-op, I'm not as confident that there will be an effect post-op.
Well, it's similar to the concept of buy-in, right?
Correct.
Yeah.
Buy-in is a great way to put it. And then we do preemptive. So before you feel pain, we're making sure your pain centers are blocked. Before you feel nauseous, we make sure your nausea centers are blocked. So, the surgery becomes a non-event. All the preparation before, like if you were going to do skydiving or scuba diving, if you don't prepare before, the outcomes are not as good.
No, that drowning sensation's bad.
So I like all of the drama, all the preparation to occur outside of the hospital. Huh. We use these techniques so they never feel pain. They never get the sensation of nausea, which patients can get after anesthesia.
You do a cocktail, that cocktail?
Yes.
Yeah.
And they're ready, they're drinking the night of surgery and ready to go home the next morning. All right. I mean, it's not magic. There are still risks to surgery.
Sure.
But
because you're going under anesthesia.
Correct.
So there's always that risk.
But the whole being hit by a truck, we've mitigated that.
So how did you come about finding those ways to mitigate that? Because that's totally brilliant. It makes it more approachable. There's still a major commitment afterwards, though, because you change your eating habits. You drink liquid for a long time.
Yeah, and part of the prehabilitation is education. And, everyone sees a nutritionist, but they also see a behavioral health specialist. And they see, we make sure their exercise tolerance is enough, not just to handle this smooth, wonderful operation, but if there's a problem, I want them healthy enough to be able to get through a problem. Because problems do occur.
So you're taking their resistance and you're making it higher.
Correct.
Yeah.
There's a huge, we used to think about 20 to 30% of morbidly obese patients, and that's what we're talking about.
That's over 100 pounds?
75 to 100 pounds overweight, had sleep apnea, but it's probably over 50%. It may even be higher. So sleep apnea means you stop breathing during the night.
Yeah, I know somebody who does that. It's alarming.
Right. And all their, the stress response to your body does damage to your heart, to your kidneys. And you can reverse that by wearing CPAP if you have sleep apnea.
So what does that do? That forces air through. It changes your breathing pattern, doesn't it?
Well, no, it augments your breathing.
It augments it.
Yeah, okay. It doesn't change it. So when you take a deep breath, it helps keep your airways open.
Now, are you saying that you think that weight gain has something to do with so many people having to be on CPAP machines?
So the answer is, for the majority of patients, most of the diseases we're treating in 2020 are weight-related.
Right.
Diabetes for sure, high blood pressure. To the majority of patients, there's some congenital or genetic high blood pressure. Sleep apnea, definitely. And some cancers. And if you can reverse that, if you can get the patient from being morbidly obese to just being obese or just overweight, the chance of kidney failure, heart failure, liver failure
decrease significantly.
Right. And weight-related cancers decrease to a normal population.
I didn't even realize there were weight-related cancers.
There are. And one of the I lecture about this a lot, and one of the things I tell, healthcare workers, you walk in the hospital, everybody's overweight.
Yeah.
More or less.
Yeah.
Right?
Yeah.
There are no absolutes, and that's because, breast cancer, prostate cancer, colon cancer, and uterine cancer are all mediated and affected by obesity. And we're working with the other departments, right? Now at Southside, the gynecologic oncologists, we're working with them to identify patients who would benefit from weight loss before or weight loss during their surgery to treat an early endometrial cancer, that sort of thing.
Oh my goodness! I want to circle back to the enhanced recovery, but that's a theme that runs through Northwell. Is you guys all work together with the different departments, and you're trying to really augment each other's work, because we are getting very specific. Each medical area is really, really drilling down to be very, very specific. So, and I love that, because you can get really brilliant at that one area as opposed to trying to understand everything.
Right, but if you're collaborative and you spend time in the same room with people outside your specialty, for instance, with robotics, we all meet as a group. The gynecologists, the urologists, the general surgeons, the heart surgeons, and we talk about how we handle different things. And I may learn from someone else how to use an instrument in a way that I never thought to use it, because I'm learning from other general surgeons. And even now, I'm still learning. Yeah, no,
we always learn, and we always should continue to learn. That's why I do the master mindset meetings, where we put like-minded people in the room, and collaboratively we stop reinventing the wheel, because somebody else might have had an experience. Here's my issue, and has anybody else had that issue? And 9 times out of 10, 2 or 3 people in the room have had that same issue and come up with different solutions. And what they do is they jumpstart that person, and they don't have to go through that same learning curve. So they take advantage of that. So that sounds like what you're doing.
It is. And that's where the enhanced recovery came from. I mean, I learned a lot from my colorectal partner, who, I helped him start his program. He helped me start my program, even though we're both working on different ends of the human body. Yeah. Because there are common themes.
Yeah. No, I love the fact that you're seeing that, and you're looking outside and being collaborative. Some people get crazy about doing things like that, and they feel like they're less important by going outside their field, and it's anything but collaboration. I know Michael hears this almost every week is the center theme for everything that I talk talk about is really important. The collaborative mind is so much more effective than the singular.
And it goes beyond just the doctors being together. All of our programs are inclusive and collaborative, and the nurses are involved, the technicians are involved, and everyone has a voice, and everyone really can contribute to safety and quality.
I totally agree with that, and it's great that we're in that kind of environment, and Northwell Health is really well known for that. You're listening to Healthy Lifestyle. I'm Lori-Ann Casdia. We are speaking to Dr. Dominick Gadaleta, the chair of surgery for Southside Hospital, and we will be right back. Don't go away. Welcome back to Healthy Lifestyle. I'm Lori-Ann. If you have any questions, comments, or ideas you'd like to hear more about, please email us at healthylifestylewithla@gmail.com. And of course, follow us on social media at Healthy Lifestyle with LA. We love hearing from you, and we answer every email and post personally. And again, we'll be live streaming on Facebook starting in April, so don't miss out on that. In the meantime, we are here with the great, wonderful Dr. Dominick Gadaleta, chair of the Department of Surgery in Southside, and we were talking about the bariatric surgery program that he really started over in Southside Hospital. You've been doing this since the 90s, and you are using something which gets me really crazy excited because I really have a great regard for this particular person. So you are using the Da Vinci robot, correct?
Correct.
Oh my gosh. How are you doing robotic surgeries, and how do you use this? And tell us all about it, because I think Da Vinci he was amazing. The stuff that he came up with, and you're actually using that robot. How cool are you?
Wow. We're going to have to tape this and play it again over and over again.
Fair enough.
So, the robotic platform has been around for a long time. The actual robot has been in several generations. We're now using what's called the XI. I don't know if it means 11 or but it's the newest robot. And the way I explain robotic surgery to patients, because they all ask, is, we know about traditional surgery where you make an incision.
Right.
All right. Laparoscopic surgery, we actually put tubes through the body and then stick instruments through the tubes. If my hands, and I have two of them, are attached to the instruments, then that's traditional laparoscopic surgery.
Right.
All right. We can't do much with just two hands. So you need to have an assistant. You need to have a camera port. So you have 5 tubes, but it involves more people. And with more people, there's more conversation. There's has to be some mind reading going on.
Sure.
And people can't hold things as well as a machine.
Sure.
So if I attach the same instruments, slightly different, to a machine, and I control the machine, all of a sudden now I have 4 or 5 arms. I have a camera that doesn't move. They can actually make the camera have the technology so that it's 3-dimensional without wearing goggles, because there's too much weight to carry that without the machine.
Right.
So, and the instruments can have wrists. You can't, right. So you're able to do all sorts of maneuvers more naturally, like you had open surgery.
Right.
By going through the tubes and attaching the special instruments to the machine.
How long did it take you to train on this device or these devices? Because they've kind of morphed into more and more usable and functional, right?
So the company, and we don't like talking about companies, but the company that makes the Da Vinci robot is called Intuitive.
Right.
And it's for a reason. So it is intuitive. It really is helpful if you're a skilled open surgeon and laparoscopic surgeon.
Which you are.
Which I'm told.
Which you are.
So marrying the two technologies is really very. It's a quick learning curve. They're very, very. We're studying this in depth at the Zucker School of Medicine at Hofstra Northwell, and it's very protocolized. So new people coming in have to go through a rigorous training period with classwork, online work.
So they're learning that now.
Yeah, there are people who have been in practice for years that are learning it now, but even for the young people. And the young people are very skilled with the video games and handling their cell phones at doing robotic
this is second nature
and
to them.
laparoscopic surgery. They're used to looking at screens.
So now do the new students who are going to be future doctors, are they still doing open surgery and laparoscopic surgery and then going to robotics, or are they just going right to robotics?
No, they're doing all three simultaneously.
Yeah.
And part of my job as an educator is to pause when it's appropriate and say, well, how would you do this if we didn't have the machine?
Yeah, what if the machine fails?
Correct.
Are can you go back in and do it regularly?
Yeah, we just switch out the instruments to hand instruments instead of robot instruments.
Yeah.
But even open, I mean, if we had to open right now, where would you make the incision and how would you do this part differently?
Brilliant.
And all the rest of it. So I think learning that way, being able to see in three different platforms at the same time is my obligation to the person in front of me. So you're really learning three operations when you're doing the one.
Yeah, that must be an amazing curve. So now when your patients come in for bariatric surgery, do you give them the option? And does anybody have a problem with you using robotics? I think it would be cool. I just want to be awake while you did it.
No, nobody has a problem with it. Some centers, there are access issues. Okay, so the robot's very expensive.
Okay.
They don't have one in every corner.
Gotcha.
And it's also a large piece of equipment, so it doesn't fit in every room. We're fortunate at Southside that there is no access issue. So part of my coming over from Manhasset, North Shore Manhasset, was they contracted out to get a second surgical robot. So there is no access issue. So I offer it to every patient. Some patients are not appropriate due to anatomic considerations, prior surgery, things like that. It is an expensive modality, so if I feel that the benefit to that particular patient is minimal, I would not use it. But more than 90% of what I'm doing at Southside is on the robotic platform.
I was just going to ask you that question. See, you do read minds. See, this is why you're so successful at what you do. Yeah, no, I think that's so interesting that you can do that. It reminds me, I don't know if you ever saw the movie Dave, but and he plays the president. Remember, he puts his hands in the robot and he goes, "The fish, I caught a fish this big," and it was really great. So that's the visual I get when you're talking about this.
It's also excellent for things like STEM programs. So we bring the high schoolers to the hospital, to the training areas, so they can get excited about career in science and medicine. Yeah,
if I didn't do that passing out thing, I'd feel that would be really cool to do. But the passing out thing doesn't really go really well when you're doing surgery.
No.
So what do you think? How do you think the surgical procedures have changed since you started?
I think the main thing is our understanding of preemptive analgesia, preemptive anesthesia, and the importance of minimally invasive surgery. It was really heresy in the 80s when people were saying they could take out a gallbladder through little tubes.
Yeah.
Even though the gynecologists were doing a lot of work laparoscopically well before. To be able to attach a camera to the telescope or the laparoscope really revolutionized everything, because the early laparoscopy was done with your eyeball to the scope, just like the early colonoscopies were done the same way.
Yeah.
Now you're doing this and you're looking up at a screen rather than having to have your eye in the device.
Right.
So there's magnification, there's enhanced, there's 3D, HD, all of that stuff.
That's just telling me that good communication keeps going back, and that's why it's evolving the way that it is. So it can only get better from here, which leads me to my next question. What does surgery look like in the next 5-10 years? What do you think?
I think there's more automation. I think, again, the actual...
You'll be able to do it from an app on your phone?
It's not recommended. But no, there's no reason why someone, and this is where I wanted to go, so thank you for that. There's no reason why I can't get a phone call from my colleague and look at what's going on in the operating room on my phone and help direct my colleague.
Yeah.
There's no reason why artificial intelligence, which is one of my interests right now, that we can't just push a button on the computer, the robotic computer, to say, do I have everything the way it's supposed to be? Is it time to cut now, or to do the new connection, that sort of thing?
Yeah.
The technology is there. And we just have to be dedicated to doing it, and that will improve the safety of the surgery.
It's funny that you said that you should be able to look at whatever they're doing while they're doing it on your phone if need be. But I know that some restaurants, they have sister restaurants in California, and obviously they're going after the New York restaurant does. Right. So they literally get on what we would refer to similar to a Zoom call, and they tell them what worked, what didn't work, what was selling, what wasn't selling. So the California restaurant has kind of a leg up because they experiment here in New York, find what's successful and share it with them. And then in the morning, they share the reverse with the New York store, the restaurant. Right. So it's kind of similar, where we're absolutely utilizing technology to help one another. And there's that word again, collaborate. So just stepping back for a second, when all this stuff started coming out, all these new surgeries, you've been a surgeon for some time. You have a lot of experience. Were you resistant to some of these newfangled, crazy ideas, which end up being really substantially useful? Or are you one of those visionaries?
Well, there were things over the years that I was resistant to, but technology was not one of them. The surgical robot existed before anyone knew what to do with it. So being one of the people that figured out where it would help and where it wouldn't help is really something that excites me.
Yeah, you're a visionary without a doubt. So before I ask your why, because I'm going to ask your why, is what advice, if you were able to give any advice out, would you give to medical students debating getting into the surgical area?
I think it's still a very competitive area. I think they need to make sure they're at a good program, and that they do well on all their rotations. There are lifestyle issues, but my philosophy has always been, if I have to either change the job or change myself. And if it's something I really love, then I work towards getting the job to suit me. Yeah. But without putting the time, it doesn't happen on day one.
Right.
But I love what I do. I'm so glad I'm doing it. But, I couldn't be a department chair 20 years ago.
Understood. Right? Yeah. Well,
and that's really the best advice to give the young people moving up.
And so never having gone through a medical program, the surgical area, the reason why you have to do all the other rotations is that's really like the preem area to go into, but you got to know a lot about a lot.
Correct.
Yeah.
Correct.
So they really need to spend that upfront time, make that commitment and dedication. I think anybody who goes into medicine kind of does that, but definitely into surgery. My brother's a neonatologist, so I know the commitment he had to make.
Tremendous.
Yeah, and still makes, and the amount of time that you spend. And as you get used to what you do, obviously it comes more natural to you, but there's a huge commitment of time and weekends and nights. And
you always have to remember what's on the line.
Yeah.
Right?
Yeah.
It's a person, a baby, or whatever in front of you.
Yeah, it's a lot of responsibility, and yet you do it swimmingly. So here's the question of the day. So why did you get into medicine, and then why surgery? What made you go there?
So you have a pretty broad audience, so I'm going to probably not appeal to most of them. But growing up, I had my father was an immigrant. He had his own business. It was a factory. I worked in the factory from when I was young. It's past the statute of limitations, so no one's going to go after him. But I was able to deal with everyone.
Different family. You can ask your family to do anything.
I was dealing with attorneys, with accountants, with every aspect of life. And then my grandmother got sick, and she eventually passed. And I realized at that point that I can read a book and know how to do math and do fake law, at least to keep myself out of trouble.
Right.
But I can't do fake medicine. I really, and it was the thing that challenged me, and I thought I can do the most to help my family, and by extension, help everyone else's family.
Yeah.
So that's really what was the turning point for me, is knowing that I could rely on other people and believe them when they say I owe some money to the federal government in taxes.
Right.
But I needed to know as much as the doctors taking care of me and my family to be comfortable in life.
Yeah. So it was a very important moment when your grandma passed, and it really significantly impacted you, and enough to know that you wanted to take control in that area, and it became your wheelhouse.
Right.
And you hire people to do your numbers and tell you what taxes you owe.
Right.
So and we should always be in our wheelhouse, and it's things like that. Your why is incredible, because it goes to what we speak about here, is that you need to go after your passion, and passion comes from usually something that's happened in your life. So my brother's a neonatologist. I used to have a younger sister. She only lasted, I think, 5 hours. We thought it was 5 days, but it was 5 hours when I looked it up. And she had a respiratory issue, and I think my brother felt, and I don't mean to speak for him, but I have to only imagine, because I was only 24 months old, the feeling of no control, of not being able to do anything and seeing everybody around you suffering and in pain. And he ended up becoming a neonatologist. And my other brother, who is a retired Air Force colonel, his daughter, the only girl of all of our children, she was named after our younger sister, Lisa. So it definitely impacted them. And I only connected those dots about a year ago.
No, it's extremely important. Yeah. And again, it depends where you want the control in your life. Some people are money people, right? Yeah. So they would never let anybody handle their money.
Right.
And that's where their life led them.
Absolutely. So. Absolutely. I don't like doing numbers. That's why I'm in marketing and I mentor. So I didn't do that third M, which is the money. So hopefully that always comes. So that's not a problem. But I love your whole approach to things. Obviously, you have a wildly successful program here at Northwell, and the bariatric surgery is something that I've seen a number of my friends go through.
Yes.
And very, very successfully, and there's a pride behind it that they were, they had this struggle, this fight, they weren't able to get over the hump, and no matter what they did, they couldn't lose the weight. Then they had the procedure done, and they're so healthy, they're so active, they're so happy. I think it's a really great thing that you give back to people by doing this. I know you do other surgery, but this in particular.
And seeing the before and after, and actually, I really enjoy hearing these stories, especially before.
What's your favorite story that you've heard, without revealing the patient?
There are a lot of life-changing events, lifestyle things, but one of the things that really warms me is when I see a family member or a patient 10 or 15 or 20 years later, and they talk about how they wouldn't have been able to skydive, or they wouldn't even be alive if they didn't have the surgery 10 or 15 years ago. It makes me feel like I'm making a difference.
Well, you definitely are making a difference. Now, in order to have a surgery like that, you have to be about 100 pounds, 75 to 100 pounds overweight?
Yeah, so 75 pounds overweight, and we go more by body mass index, and, your doctor should tell you what your body mass index is at every visit, especially your annual, but over 30 is considered obese, and that's a height to weight ratio. Over 35 is morbidly obese if you have a weight-related comorbidity like diabetes, hypertension, sleep apnea, and over 40, 100% is morbidly obese. The interesting part, and where the future is going though with bariatric surgery, is the cutoff was a BMI of 40,
right?
And that was based on actuary tables. That said, if you had a BMI over 40 and you underwent 1980s weight loss surgery, the risks of surgery balanced out at 100 pounds overweight or more.
Gotcha.
No one's willing to do the study now that says where the risks lie, but we are doing patients with a BMI of 30, so 50 pounds overweight with diabetes, and really having outstanding results.
Yeah.
So the number is not 40. I think we wait too long to intervene. But that's what's generally accepted and covered in most insurance plans.
Gosh, you read my mind again. I was going to ask you if it was covered.
Yes.
So if you had one thing quickly to say, what would it be to the listeners here relative to surgery and what you're doing?
I think the most important thing health-wise is if you're struggling with your weight and you think you might be a candidate, even if you're not sure you want to go through with it, you should enroll in a program. We have a comprehensive program. We take all comers. Some patients go down the surgery route. Some patients we're able to help with a combination of medication and other things. But pretending it's going to go away or wishing it away or saying you'll do it next year or on your next birthday is not going to make the change.
No, and you might not make it to your next birthday.
In some cases, that is true.
Doc, thank you so much for being on. This has been really a great show. I appreciate it. Thank you all for joining us today on Healthy Lifestyle. My heart is always lifted by sharing this time with you. I want to thank our guest today, Dr. Dominick Gadaleta. He is the Chief of the Department of Surgery for Southside. Thank you so much. You're just inspiring.
It was my pleasure.
So I say this a lot. We're here to serve one another, but especially in these times, I want you to take a moment, step out of your day, do a little something for someone else. Think of other people that are around you. We're not just here by ourselves. There's a reason for that. And remember, do a little something for yourself every day. It starts there. It takes 21 days to build a habit, 90 days to build a lifestyle. So start with one new habit today. Maybe it's signing up and getting more information about bariatric surgery that's available out there. So remember, it doesn't have to be big, just something for yourself. In the meantime, thank you again for joining us on Healthy Lifestyle. I'm Lori-Ann Casdia. Until next time, play a higher role, serve a higher purpose, show up for you, and show up big.